Welcome to Evidence Mastery with Dr. Masood Tusi. I will help you understand what systemic lupus erythematosus is and how it is managed. Please note that this video is for education only and will not replace your doctor's advice. Systemic lupus erythematosus, or SLE, is a chronic multi-system inflammatory disorder. Its root cause is autoimmune, meaning the body's natural defense mechanisms misidentify healthy native tissues as foreign threats. This data visualization compares the demographic incidence of SLE. It shows a striking divide, with incidence roughly 10-to-1 higher in women, particularly those of childbearing age, compared to men. Furthermore, clinical data shows the disease is both more common and more severe among Black and Asian patients than among white patients. The exact etiology involves unknown environmental triggers acting on individuals with specific genetic predispositions. In some cases, a reversible lupus-like syndrome can be directly induced by medications, such as hydralazine or certain tumor necrosis factor, or TNF, inhibitors. SLE is uniquely dangerous because it is not localized to a single organ. It is a systemic failure, granting the body the ability to weaponize its own defenses against virtually any internal system. The clinical onset of SLE is highly variable. It can develop abruptly with high fever and sudden multi-system failure, or it can creep in insidiously over months or years, presenting as intermittent malaise and joint pain. Joint symptoms are the most frequent early indicator, occurring in approximately 90% of patients. This ranges from transient aches to acute polyarthritis. Unlike the bone erosion seen in rheumatoid arthritis, lupus polyarthritis is typically non-destructive. Prolonged disease can still cause physical deformities. A condition known as Jacquard arthritis can develop, where ligamentous laxity, rather than bone or cartilage erosion, leads to reducible ulnar drift or swan neck deformities in the fingers. Moving to the skin, the classic cutaneous finding is the malar butterfly erythema. This is a flat or raised red rash across the cheeks and bridge of the nose. A critical diagnostic detail here is that this rash specifically spares the nasolabial folds, the creases running from the nose to the corners of the mouth. Other visible signs include severe photosensitivity, reversible hair loss during active phases, and recurrent ulcers on the hard palate and nasal septum. Patients may also experience Raynaud syndrome, where vasospasm causes distinct blanching and cyanosis in the fingers and toes in response to cold. Joint pain and skin lesions represent the external manifestations of a disease that originates deep within the body's autoimmune signaling pathways. When SLE targets the internal organs, the cardiopulmonary system is frequently involved. Patients commonly develop recurrent pleurisy, often with pleural effusions. Cardiac complications are also significant, most notably pericarditis, along with accelerated atherosclerosis, which drives long-term morbidity. The central nervous system is equally vulnerable. Mild cognitive impairment is common, but the disease can trigger severe neurologic events, including ischemic strokes, seizures, transverse myelitis, and distinct personality changes or psychoses. In the blood, SLE routinely disrupts standard cell counts. This presents as anemia, leukopenia, which is a reduction in white blood cells, and thrombocytopenia, a potentially life-threatening drop in platelets. For pregnant patients, these systemic disruptions pose severe obstetric risks. There is a high probability of early and late fetal loss. Additionally, if the mother carries specific anti-Ro or SSA antibodies, the neonate is at risk for developing congenital heart block. The most critical internal threat is often lupus nephritis. Renal involvement can develop at any time and may range from asymptomatic proteinuria to potentially fatal glomerulonephritis. Because early kidney disease is often completely silent, vigilant regular urinalysis is an absolute clinical requirement. Because SLE can quietly attack the brain, heart, and kidneys simultaneously, relying solely on physical symptoms is insufficient. Rapid, precise laboratory diagnosis becomes a matter of life and death. This laboratory algorithm breaks down the classification criteria developed by the European League Against Rheumatism and the American College of Rheumatology, or EULAR-ACR. Diagnosing SLE requires a strict matrix of clinical findings paired with specific immunologic serology. The initial screening net is the antinuclear antibody, or ANA, test. A positive ANA occurs in over 95% of SLE patients, making it highly sensitive. However, it lacks specificity, up to 30%. While these are not present in every patient, their detection provides a definitive diagnosis for SLE. Once diagnosed, tracking disease activity requires monitoring serum complement proteins, specifically C3 and C4. These levels frequently drop during active disease flares, particularly in patients with active nephritis, serving as a real-time gauge of inflammation. If nephritis is suspected, a physical renal biopsy is an absolute clinical requirement. Blood tests alone cannot reveal the extent of glomerular sclerosis or active inflammation. The histologic findings dictate exactly how aggressively the physician must deploy immunosuppressive therapy. Diagnosing SLE is never a single blood test. It is a calculated triangulation of sensitive screening, highly specific antibody markers, and physical tissue evidence. Because SLE manifests so broadly, treatment follows a severity stratified approach. Medications are escalated sequentially, dictated strictly by which organ systems are involved and the level of active inflammation. The foundational base of this pharmacological pyramid is the antimalarial drug hydroxychloroquine. It is indicated for virtually all patients because it actively reduces disease flares and decreases overall mortality. However, baseline screening for glucose 6-phosphate dehydrogenase, or G6PD, deficiency, along with regular ophthalmic exams to prevent toxic retinopathy, are required. For mild to moderate disease, where joint and skin symptoms predominate, the middle tier utilizes nonsteroidal anti-inflammatory drugs, as well as immunosuppressants like methotrexate or azathioprine, to control localized inflammation without resorting to heavy steroids. The top tier is reserved for severe active disease, such as lupus nephritis or central nervous system involvement. Here, induction therapy requires high doses of intravenous corticosteroids paired with highly potent immunosuppressants, like cyclophosphamide or mycophenolate mofetil. Modern treatment also integrates targeted biologics, such as belimumab and voclosporin, which offer better renal responses. Looking forward, there is promising data emerging on the use of CD19 chimeric antigen receptor, or CAR, T-cell therapy to reset the immune system in refractory cases. The ultimate pharmacological goal is straightforward: hit the disease hard during an acute flare to rapidly induce remission, and then quickly taper the corticosteroids down to the absolute lowest possible maintenance dose to avoid permanent drug-induced toxicity. Managing pregnancy in SLE requires strict protocol adherence. Because active disease drives poor fetal outcomes, patients are advised to time conception only after achieving at least 6 months of clinical remission, and they must remain on hydroxychloroquine throughout the pregnancy. Due to a high risk of congenital malformations, teratogenic maintenance drugs like mycophenolate mofetil must be stopped and transitioned to safer alternatives. Furthermore, if the patient has coexisting antiphospholipid syndrome, or APS, prophylactic anticoagulants are strictly required to prevent thrombosis and late-stage fetal loss. This survival curve graph plots the long-term prognosis of SLE patients. It demonstrates that thanks to earlier diagnostics and evidence-based therapies, the 10-year survival rate in high-resource countries now approaches 90%. Yet patient survival remains marginally lower than the general population. The persisting mortality risks are no longer acute organ failure alone, but the downstream effects of chronic inflammation and immunosuppressive treatment, specifically premature cardiovascular disease and opportunistic infections. The modern prognosis for SLE is characterized by high survival rates, yet it remains a chronic condition requiring multidisciplinary risk management to address cardiovascular health and potential organ failure. It is also vital to distinguish true systemic disease from isolated cutaneous variants. The most distinct of these is discoid lupus erythematosus, or DLE. DLE typically clusters in light-exposed areas, like the face, scalp, and ears. If left untreated, these erythematous plaques progress into permanent atrophic scarring and can cause widespread, irreversible hair loss. Contrast this with subacute cutaneous lupus erythematosus, or SCLE. While SCLE also triggers extensive, highly photosensitive rashes with annular or psoriasiform lesions, they rarely result in permanent scarring. Because these variants lack severe internal organ involvement, Localized treatment focuses heavily on strict photoprotection, topical corticosteroids, and, for resistant lesions, the addition of systemic antimalarials. I hope you enjoyed this video. Please feel free to share your experience or questions in the comments. If you found this video helpful, don't forget to subscribe to my channel. If you would like to have a resource explaining diseases, medical conditions, therapies, and drugs in plain language, I am writing a book which will be published in 2027. Its title is Real-World Medicine, Diseases and Drugs. Stay tuned.